very warm welcome to everybody. And on behalf of Professor Satish, I'm also here to welcome all our panelists, our speakers, and also all our participants. So this is our fourth series in the sequence, and the webinar today for all the participants and also the panelists, it's on fortifying, it's on discussion. The panel discussion is on discussions circling around fortifying our health in South Asia, with a focus on nutrition, coastal risk, and urban heat. And we have chosen these topics because these are the themes that our group will be working towards, and we wanted to integrate it and look at it from the angle of health perspective. So that's why we're very specific, choosing on food nutrition, also on the risk of the communities living in the coast. So what could be the health risks associated with it? And also because of the modern day modernization, what are the various risks faced in our urban community, which is now named as urban heat here in this webinar. So that's how we are going to do it. Let me just take you through the introduction of chairs and panelists by Joshitha, followed by a panel discussion for almost 1 hour. Dr. Mute. Okay. So then we have a panel discussion for 1 hour, 10 minutes, almost 1 hour, 20 minutes, sorry. We'll take a short break after the panel discussion for 10 minutes just to stretch your legs and drink water, tea, coffee, as you feel. And then we will move over to our talks, which will be chaired by Dr. Paramesh. So Dr. Paramesh will be chairing both the panel discussion as well as the chair, and it will be moderated by Joshitha. And also we would request Dr. Paramesh to give her remarks at the end of the session. So with that, we'll move to the next slide, please, Joshitha. I know many panelists have already been here for our opening, where we discussed how we operate, where we operate, and I have already discussed that we have 4 themes. That's on food, the coastal resilience, sustainable communities. And today what we are going to do is all the associated health risks. So we would want to learn from you, what are the health risks associated with these other 3 themes, which we have envisioned as a program here at South Asia. So we function through various secretariats, and the one for South Asia is here in Divecha Center for Climate Change. That's where most of our organizers and our group are also stationed. So that's in the Indian Institute of Science in Bangalore. Next, and I would also request our organizers to put a web link to Future Earth and also to our South Asia microsite. So all the information, if the participants would like to gather, you can go through our website there. So in the chat box, our organizers will be placing those links for you during this webinar. How we plan it right now, we do have 3 webinars already over. Today is the 4th one. And with that, we want to transcend into what we call the working committee group. So where we plan to curate a program with you, have chapters ready for a South Asia Regional Summit, probably at the end of this year or February. And we would want to meet in person to discuss how can we bring about changes. What are the various system changes needed in order to have health as a priority in most of our countries? And what are the priorities needed in terms of food, nutrition, also communities living in the coast, and also for climate risks? So that is what we plan to do. And with your help, we look forward to your guidance as well as your advice on how to go forward, for which we'll be in touch with you over these weeks and also after the webinar up to December or February of 2023 and beyond. Next. Just want to introduce all our brilliant organizers here and coordinators. So today we have Joshitha with us. For the rest of the webinars, we had other members who you can see on the screen. So our organization is headed by Professor S.K. Satish, who is also the chair of the Divecha Center for Climate Change and a director, and also he's a dean for administration and planning in the Indian Institute of Science. So a very warm welcome from his side, a message from him. And we would be engaging with all of you even at the closing, that's on the 29th of April. Just wanted to do a quick brief of how our webinars were placed. So we did have the first one in January, second, third one just last week, and the fourth one is today on fortifying health, and the next one will be on talks related to sustainable development practices and how best could regional planning be placed for India. So that's our last and the final webinar of the series. Next. These are all our chairs that have been chairing all the sessions, and today very proud and very glad to introduce Dr. Paramesh, who is a pediatrician pulmonologist. He's won various awards, and I will leave for Joshitha to give a brief about him in detail. But he's been there, he just inspires us despite his... I was logged out, sorry. So he inspires us in many ways, and it's so good to have a colleague of that age with me. So welcome, Dr. Paramesh. And with that, I will now hand it over to Joshitha to introduce the speakers, the chair, and allow Dr. Paramesh also to chair it. So Dr. Joshitha, you can go ahead.
Thank you, Smriti. Thank you for that wonderful introduction. Good morning, everyone. I welcome you all to the fourth webinar in the South Asia webinar series titled Fortifying Health in South Asia, a focus on nutrition, coastal risk, and urban heat. So Dr. Paramesh will be chairing this session, and Dr. Paramesh is a pediatric pulmonologist and environmentalist. He was the leading doctor in handling the H1N1 cases when it was at its peak during the 2009-10 in Karnataka. He was the chairman, H1N1 Core Committee, Government of Karnataka 2015. He was the facilitator, panelist, and advisor to the health projects of WHO, UNICEF, UNDP, and the Commission of Macroeconomics and Health, Government of India. He has won the Lifetime Achievement Award for the year 2006 on allergy, asthma, and immunology by the International Asthma Forum, Denver, USA in 2007. He is a visiting professor in USA, Nepal, Canada, UK, Australia, and Italy. He is also a visiting professor at Divecha Center for Climate Change. So coming to the speakers. First, we have Dr. Aakash Shrivastava. He is presently the head, Center of Environmental Health and Occupational Health, Climate Change and Health at National Center for Disease Control. Prior to this, he has served other organizations inclusive of ICMR, Indian Armed Forces, and UNICEF. He has been part of the founding team of the Integrated Disease Surveillance Program at NCDC and served the Epidemiology Division at NCDC. The next speaker for the day is Dr. Aditya Pradhimna. He is a faculty member of School of Development at Azim Premji University. He teaches courses on environmental health and public health, in addition to facilitating research projects in the area of climate change, pollution, health impact assessment, and occupational health. Besides this, he also provides technical and administrative support to a range of nonprofit organizations such as Healthy Allergy Initiative, Pesticide Action Network, and Sochara in India. Next, we have Dr. Khin, served as a government staff member from 1975 till 2010 and retired as a director of Central Health Education Bureau, Ministry of Health, Myanmar. After retirement, he continues teaching postgraduate students at the University of Public Health as an honorary professor and advisor for public health domain for the Ministry of Health and Sports. He is a founding member of the Green Economy and Green Growth Association since 2011 and a board member of the ASEAN Institute of Green Economy up till now. The next speaker is Dr. Paraske Pokhrel. He is currently the Professor and Chief for the School of Public Health and Community Medicine at the BP Koirala Institute of Health Sciences. He has more than 27 years of experience in medical education and a strong background in community medicine and public health. At present, he is also a member of the Academic Committee in the Indian Institute of Public Health, New Delhi. He advocates regional needs of working together to improve public health academia and practice in the region. He also worked as a regional technical advisor, WHO Southeast Asia Advisory Committee on Health Research. And the next speaker is Dr. Shakil Ahmed. He is a professor of pediatrics at Dhaka Medical College. He is also the core member of the WHO Child and Adolescent TB Working Group. He is the Secretary General in Bangladesh Pediatric Pulmonology Forum and a member of the Executive Committee, Asian Pediatric Pulmonology Society. The next speaker of the day is Dr. Manu Gupta. He is the co-founder of SEEDS. Manu holds degrees in physical planning and urban planning from the School of Planning and Architecture, New Delhi, and a doctorate in community-based disaster management from Kyoto University, Japan. Over 26 years at the helm, he has mobilized community-led efforts in recovery, risk reduction, and climate change adaptation, working with a wide spectrum of communities across Asia. The final speaker is Dr. Mofisar, who was unfortunately not able to join us today. So he's a research associate at Cologne University of Applied Sciences and academic instructor. He's an environmental scientist currently investigating the impacts of adaptation to environmental change, including climate change, on social ecological systems in low-lying river deltas such as Bangladesh. Now I request Dr. Paramesh to open the panel discussion.
Okay. Thank you very much for your kind introduction, Joshitha. At the outset, I extend my sincere thanks to Professor Satish, the chairman of Divecha Center Climate Change and the director of the Future Earth, along with Deputy Director, Dr. Priti Basnet, and all the coordinator helping our moderator helping this program. And we all know that we are thinking of we have to progress. No country can progress with ill health, ill wealth, and illiteracy. And also these values has to come with the biodiversity. If we have good health, health is the primary focus. If we have good health, you work harder, you earn more, your wealth increases, naturally the quality education, they're all interrelated. So health is the primary focus for sustainable living of the human being and the planet. They're all interrelated. We are in the crucial stage for the survival from climate change with the existing carbon dioxide level almost 450 parts per million. We are a very crucial stage. It is time for us to not to teach, act. Now, we know our survival, we need air, water, and food. There are three important things. You cannot live without breathing for 3 minutes. You cannot live without drinking water for 3 days. You cannot live without eating food for 3 weeks. 3 is very important in all this. So now we are highlighting the concept of the program, what we have mentioned about fortifying the health of the South Asia. We are focusing on 3 important things. One is the nutrition and urban heat and coastal risk. What are the health problems we are going to face from these things going to happen? Of course, Nepal away from this coastal area, they are safe in that context. Now, how each one of your country health systems sensitize these issues, we like to hear from you, and how we can act like a catalyst to tackle the situation with solution to act at the community level, at the institution level. These are all the few things you are going to learn. 2 questions has been prepared by our moderator. It has been circulated for all the speakers. You have 3 minutes time. Let's keep the respective time. I think let's stick to the time. And when you're talking the extra thing, you can add to that. Over to our moderator.
Thank you, sir. So the first question is, how prepared are the health systems in sensitizing the health risks in terms of nutrition, coastal risks, and urban heat? Do you think the health systems are prepared to tackle these issues with the changing climate? So Dr. Paramesh will be reading out the list. So I think it's Dr. Aakash who's going to start with the answers.
Good morning, everyone, and thank you for giving this opportunity. I'm speaking from India.
Something else.
And the 3 aspects that has been identified in the talk today related to nutrition, coastal risk, and urban heat. I think all 3 of them are very relevant to the context of India. India for long has grappled with the issues of malnutrition in children. Also, there are issues of food security, and the challenges that we face now of climate change is likely only to enhance these issues, and a lot needs to be done with all sectors. The health sector also requires to respond to them. India also has a very long coastline. Many of the states have coastal districts, and they face enormous troubles of cyclones and other coastal risks. And the next stage, of course, urban heat. Not only are many of the inland states in the country affected by very high rise in temperatures, high max and high minimum temperatures, issues of humidity, trap in urban cities of giving and island effect of heat. All of those challenges are very much true for these metropolitan cities of India as well. Now, looking into the general population of the country, I do not really see that climate change is still been accepted as an emergency by the general population. This is one of the major issues that we have about sensitization and the role of the health sector to play, because general population would see climate change as something that is distant, something that will probably affect only the future generation, or something that is not a priority for them today, looking at the plethora of health issues that exist. And they find it very difficult to relate the association of climate change with the health issues that they face today. And the same is also true of the medical community. The medical community which exists today in the country did not ever study climate change as a subject in their curriculum. It still does not exist in the country. And therefore, doctors do not understand it very well. They do not question the environmental variables when they are making patient profiles for diagnostics. And therefore, there is a huge challenge of sensitization of these subjects by the health sector. And I do think it's something that's worth addressing. Efforts have been made by various partners. I have nothing to say on that. But now in 2019, we have started a new program, health program by the Ministry of Health, which is a national program on climate change and human health. And through this program, which have existence in all the states and districts of the country, we are trying to address these gaps simultaneously. And it will no doubt take time, but the efforts have already started. The nutritional deficiencies, the post-cyclone impacts, and the heat waves are some of the things that have already been addressed in the country through existing resources, but this program will help to streamline them in the main course of combat against climate change. And we are hopeful that we'll be able to sensitize our professionals as well as the population towards these impacts. Thank you.
Thank you very much, Dr. Aakash Shrivastava. May I call on Dr. Aditya Pradhimna, please?
Yes. Yes. Hi, good morning, everyone. Thank you for very nice to meet all of you. Briefly, to respond to the question, our health tackle undernutrition, coastal risk, and urban health in urban heat in a changing climate. If we ask if health systems are prepared, there may be an implicit assumption these problems don't already exist, or that they are being addressed adequately at the moment. This is definitely not the case. So if you take a couple of steps back, and we can first look at food security. And here I'll be reiterating some of the points that Dr. Aakash has mentioned. So there are this undernutrition and food security have been so many programs have been put into place to address this challenge, production and from the perspective of distribution and access to food. Also focusing specifically on women and children. Now, unfortunately, undernutrition is still very prevalent, and it may have even context of the COVID pandemic. So given this situation, we definitely can't say that we are prepared to tackle nutrition and food security in a changing climate, because climate change is a multiplier of existing facing these challenges. But yes, we can definitely prepare, but it is not yet the case. So that opportunity is still not lost. to the 6th assessment report that has been recently released, it suggests that there is still the opportunity to address some of these challenges. This is one part of the solution, as was mentioned by the former speaker. It cannot provide the entire solution, but it is one part of the solution. In the context of urban heat, the experience of tackling urban heat systematically is a little more recent, in the last decade, actually. And it is primarily focused on early warning systems and the health system response. Putting together these heat action plans, but these may not have adequately considered the dimensions of urbanization. And I'll talk about that more later when I'm giving my presentation. But the heat action plans will be useful if implemented well. But if the broader challenges of urbanization, the demographic and epidemiological transition that the country is undergoing addressed, then we may not be able to address it adequately. I'll stop.
Thank you, Aditya. So nice of you. May I call upon Dr. Khin Maung Lwin from Myanmar? Thank you, sir. Yeah, go ahead, sir. Unmute your mic, sir. Please unmute.
Okay. Good morning, everybody. And I'm very happy to see these great people talk the great topic, especially our leader of this panel mentioned about the health is the most important. And I fully agree with you, Dr. Paramesh. And
yes, thank you.
From our point of view, our health system is well aware of the nutrition. That's fine. It's an old system we have. But still, we are using the traditional education and also the services program. So we are extremely challenged by the counter communications, attracting the parents from the rural area, urban area to take the junk foods. So I really experienced personally that not only human beings, but the monkeys are also refusing to take bananas and pick up the junk foods. So there are some, taste problems with the traditional food and the junk food with added something. So this is a small challenge for our food system, nutrition, and also education system. If I have time, I can tell you, but today I'm in a big pressure. I have to leave at 11 for some emergency activities, but I would like to continue a little more on the urban heat. The urban heat is an unexpected one, and I really appreciate this organizing team to raise this issue. When we studied some areas, for example, like Yangon, there's a issue of urban heat islands formed right in the middle of Yangon. The reason is we have town plan and the extended annexes around Yangon has problem. So the town plan is there, but the uprising and building absorb the heat, release the heat, and also there is some kind of deforestation, I can say, because some of the plants are not available to protect the new buildings. So outskirts of Yangon has urban heat islands forming in many areas, and there are some studies in 2019 that indicated we have urban heat problem. But the bigger problem is the rural heat problem, because in the rural area also, like in the middle of Myanmar, the temperature in hot season is going up very, very high. And even in mountainous area where there are valleys and the urban heat increase in the town. It's accompanied with, as our chair mentioned, that the water problem. And to tell the good news that we had some problem at the ancient town Bagan, and we planned with the Indian support to get water on rainwater harvesting and something like that. So there are solutions we needed. So we have real problem with urban heat. heat issue, and we are a little bit weak in this area, not as strong as nutrition area. And the third issue on the sea level rise. This is the bigger area for us because we need information and also awareness of this sea level rise. So I am a writer also. I wrote about the sea level rise after the Nagis, because Nagis gave us a very, very big lesson, but we are human beings and we are, easily forgetting. So people used to forget the disastrous activities. So when we tried to educate our Ayavari region and Yangon region, for example, there are estimations that Yangon even have to move about 4 to 5 million people as the sea level rise problem in between 2030 to 2050. And also Ayavari region. So we will have to work together very closely with Bangladesh also, because they are also facing the same problem. So I am trying to facilitate that we human beings can overcome such kind of thing by working together, sharing some important issues and products between the two displays. If the expectation of 30 million people moved, like Sundarban also is a big problem, and we have a big problem also. But we are not prepared from a high level thing. And even we try to build some institution or some kind of buildings closer to the area where it was hit by Nagis. So there was a tsunami in 2003 that it is very strong impact on the Aceh tsunami. So these are the three things that we need to think seriously. 1, nutrition, prepared. 2, urban heat, less prepared. And 3, the sea level rise is not yet prepared.
Thank you very much, Dr. Khin, for a concluding remark. And now may I call upon Dr. Paraske Pokhrel and from Nepal. Over to you, sir.
Sir, I believe Dr. Paras has a technical issue and has dropped out. So can we go to the next speaker?
Yes, we can do that one. I think now I want to call upon my dear friend and colleague, Dr. Shakil Ahmed from my neighbor brother country, Bangladesh. Over to you, Shakil.
How are you, sir? You are looking too young day by day.
Thanks for your comments. Yes, we are all with your spirit, always will be there.
Okay, thank you very much for inviting me here. But the biography that has been presented by the organizer, all the presenters, it seems to me that I am here to learn, not to deliver. Because all the people are really, really rich in their field of work. I'm a physician. I work with the children, and I'm a professor. I'm a teacher by profession, and for that reason, I'll be talking. Probably my talk will be generalized rather than very specific with you. And from the perspective of a physician, what I feel that, can you listen to me, sir?
Yes, we are listening to you. Yes.
So, from the perspective of a physician, what I see and feel while going through this malnutrition, climate change, urban heat, and so on, I found that as a physician, we are not touching it in any area, whether it is a postgraduate teaching or an undergraduate teaching or anywhere in our curriculum. But it is touching every day of our life, every step of our life. When you go out in the morning for a hospital, it's touching us as a heat. When you come back to home, it's also touching us same way. But while we are in the work in our office, we are not giving head towards this change. We are not looking at the patient who are actually coming from the climate vulnerable area or affecting the heat. So with these few words, I conclude myself here. Probably my presentation will be later. Then I'll talk a little bit more. Thank you very much, sir.
Thank you very much, Dr. Shakil Ahmed. Now, may I call upon Dr. Manu Gupta regarding the South Asia perspective. Over to Dr. Manu Gupta.
Oh, thank you very much, Dr. Paramesh, and thank you for all the organizers. I guess I'm the odd one out here, not from the medical community, but more from the habitat community. And maybe, I guess, the expectation here, if I may, is that the medical community and the habitat community, the architects and the planners need to work together on these very, very pressing concerns. I just wanted to highlight, of course, all the three dimensions are so important, but on the urban heat issue particularly, as we are talking today, I'm sure all of you are aware that in India, in northern India in particular, we have had the hottest month of March in recorded history. And so there is a very, very clear and present danger to the lives, to the health of people. Of course, all of you learned colleagues here on the panel are much better to equipped and qualified to talk about the science and the evidence. I would like to really highlight the core of this challenge, which is the affected community, and SEEDS, the nonprofit that I represent here, engages with them almost on a daily basis. One indicator of this mortality of climate emergency is very clearly seen as we speak to our communities in low-income settlements, is the disproportionate amount of medical bills that they have to pay during these months as compared to the rest of the population, the middle class, for example. And also, we've looked at the recent MIT study which says that by the end of this century, around the South Asia region, the wet bulb temperatures will reach on occasions exceed the threshold of 35 degrees, bringing into question the whole survivability of population who are spending more than 6 hours in a day outdoors. And just to add another dimension to the heat problem, as per the ILO, productivity loss due to heat stress in India is estimated to be equivalent of 34 million full-time jobs being lost during the next decade. And agriculture and construction sector are expected to suffer the most, which actually does not augur well for us, since both of these are two large occupations in our country. And of course, cities have it worse thanks to the urban heat island effect that my previous speakers have already highlighted. We did one recent study in an urban slum in Delhi, which showed that indoor temperatures could go up by as much as 10 degrees Celsius during the day as compared to ambient temperatures outside, because of this material they use, the tin roofs, the thatch structures. And of course, this has the bearing on the health of the elderly, women, young children who are spending most of their time indoors while men are going out to work. Imagine this at scale, 50% of entire population in most of our metropolitan cities and urban areas in the South and Southeast Asia region live in low-income settlements like these, the tin roofs, the thin structures that they are. The point of highlighting these examples is to make us realize that it is important to keep the affected communities at the center of all such deliberations that we are doing today, and to restore their agency in being able to take anticipatory action and prevent future risks. So what can we do? And I think we as a community have this responsibility. And I'm saying this from the lessons that we have learned the hard way in the last 2 decades, where SEEDS has been involved on the ground engaging with communities. Last year, we worked with the National Disaster Management Authority in India to develop a house owner's guide on cool roofing solutions for homes with range of cost options, so low cost and people who can afford that. But of course, at the same time, we are also working with a lot of local innovators, because this is a new field, like many of the previous speakers said, sir, that this is something very new the communities haven't really realized the gravity of the problem. So we are, in a way, enabling an ecosystem of innovators, of local entrepreneurs on how they can really address this problem of urban heat. And I'm going to speak about this more in my presentation later. But just to end by saying that, we need to get into a campaign mode, sir, and take this problem as a disaster emergency across this region. And that only will bring us to the level of preparedness to be able to combat these problems. Thank you very much.
Thank you very much, Dr. Manu Gupta. Now, for the second question.
Yeah. So the second question is, how can we fortify the health system preparedness to tackle the above issues at both the community level and the institutional levels to help in creating solution pathways to tackle these problems?
Yes, please go ahead, sir.
Okay, right. Well, when I spoke in response to the previous question, I had this to say that while a lot of work goes on in the country, the idea was through this program to mainstream them so that they, in a systematic approach, are handled. And one of the ways in which we under this program have tried to do it is to ask the states to develop a state action plan on climate change and human health. And this action plan has got different chapters to address different climate issues. And it also includes chapters on nutrition, it includes chapters on disasters, including cyclones, it includes chapters on heat. And those states which have specific risks, like the coastal states, have also been asked to write a chapter on the specific risk to those particular districts. And the purpose why the state needs to develop their own plans, we only provide them technical support through help of certain centers of excellence who work with us, is because the challenges are unique to each location, and one for all plan would not work. For nutrition, we have the National Institute of Nutrition and the Nutrition Foundation of India, which help us in providing technical support to these states. The National Institute of Disaster Management helps us to help the state draft their cyclone-related plan. And the Indian Institute of Public Health at Ahmedabad, which has been working for quite a while on heat-related issues, have also helped us in areas related to heat. The state action plan on climate change, though it addresses this area, all these chapters have something in common so that they can address these issues. The first is to create an awareness both at the community and institutional level. So there is a sensitization in both the population as well as the professional staff that work with them. The second is to build the capacity in the workforce. Even though they understand things, they require specific trainings to address those issues. The third is a situational analysis followed by setting up a response system from the health sector. And putting up a disease surveillance system and an EVAR system wherever required. So certain problems already have an existing disease surveillance system. If there is an existing disease surveillance system, then we are only trying to update that surveillance system to incorporate climatic variables. If it does not exist, like for example, there wasn't one for heat-related illnesses, then we have established that surveillance system in the country. And the fourth is establishing an organizational framework networked with partner agencies. So not only the program has its own framework, but all agencies, as we know, is an intersectoral approach required to address these problems. We today also in panel have people from different expertise. It's required to understand what they are working and how health intersects with them. Also in area of climate change, there are various missions addressing specific areas. So it's required that we have a networking system at each local level. And the last, of course, is research into new knowledge and technology to combat challenges. And so these are some of the areas that I think are relevant. And As a personnel from the program to all people who are in the panel and the viewers, I would only like to say that we are always open to suggestion in the program and working partnership with those who are interested in working with the program with us. Thanks.
Thank you very much, Dr. Aakash Shrivastava. Now, shall we pass it on to Dr. Aditya Pradhimna, sir? Please go ahead.
Thank you, Dr. Paramesh.
Yes.
I think I'll just add briefly points that Dr. Aakash has mentioned. So when we say the fortifying health systems at community level and institutional level. So at community level, we're mainly speaking about the people. So the ability of a community to be prepared is dependent. So a community needs to be healthy, just like what Dr. Paramesh said initially. So I think the community needs to be healthy to be able to prepare for what climate change may have in store. So we need to be focused in general across India so that they can be prepared for a changing climate. In addition, the health workers' job, as we have seen also during the COVID-19 pandemic, but they are inadequately supported. It is mainly women community health workers who are facing a huge workload and getting poor financial compensation. There is a need for filling the vacant posts of the male health workers shared, and that there is better response at community level. In addition to building competence and they can do their work better at community level. Also from the health systems have to be locally responsive. Context of the program that Dr. Aakash was mentioning, this is some of the things that are being thought about, the need for being locally responsive. At an institutional level, prioritizing health and public health are, I think, the more. So this would mean investing in health, giving the necessary resources to strengthen across sectors, addressing the social determinants of health, and thinking long term, not just as they come along. Strong public health systems are needed, and also creating public health facilitate this sort of intersectoral action for health. Then other things can follow, you know, and also be in a better position to engage closely with other sectors such as agriculture or livelihood or environment, and all of this becomes critically important to address public health challenges in the context of a changing climate. So I think, yeah, I'll stop there.
Yeah, thank you very much, Dr. Aditya. Now I call upon Dr. Khin Lwin from Myanmar. Sir, over to you, sir. So please unmute, sir.
For Myanmar, we have a strong team on the national level for climate change and disaster. It's a big intersectoral organization and quite proactive. If you recently get into our country, at this time, there were some preparedness and communication hourly, regularly, not like Nagas time. So I was so worried because, you know, the cyclones are like rats. They used to come on their own developed way in the past. So we were worried that we could manage. And also we prayed for that cyclone not formed. So the depression went gone and we were safe. But anyway, it indicated that we are prepared in climate disasters. But until now, I have already mentioned the sea level rise is not yet, you know, the agenda for institution and also for the health sector. For private health, it was strongly challenged by COVID, because this COVID-19 destroyed a lot of our public health institutions and networks, and refocusing straight to the prevention and treatment. Actually, we should focus on the health promotion and protection. So this is the area we need to reorientate our health system, and we are trying. But I'm not sure the investment is still in the prevention and control side. So this is what we need in our future. But we are trying, not very successfully in this area, especially urban heat and sea level rise.
Thank you. Thank you, Dr. Kim. Now I call upon Dr. Paraske Pokhrel from Nepal. Sir, are you ready?
Yes, sir.
Yes, sir.
Yes, yeah, this is really interesting.
We'll extend 1 minute extra to you. First and second question jointly. Do it, sir. Yes.
Thank you, sir. It's very interesting that the first question I'll touch is not that the health system is not aware of it. In last 10 years, there are 3 Lancet Commission papers starting from climate change and health. The second one is the One Health, and third one is now planetary health. There are almost 25 universities in the world has the planetary health department, but where we are lacking in South Asia is to create the evidence by the institution like university. In South Asia, any university in South Asia, is there any department of planetary health so far? Not at all. So we are a little bit behind with the, we are very good in using the knowledge, but very behind in knowledge generation. We are far behind in knowledge generation out of the rest of the world. So one of the area where we can emphasize is how much we can generate the evidence. Like in Nepal, 2012 was the first to report the dengue outbreak very exponentially, and I think the Bhutan is in similar time, 1 year or 2 years later. So that dengue realized that is the climate is there was no dengue before and there is a dengue after, and people associated with the climate change. Because, and there are 3 which used to be like in Nepal, there are 3 range in geography: hilly, mountain, and Tarai. The tree which was in the mountain, now you can see in the hill. That means the migration of tree which used to be in the mountain, now it is in the hill, means the temperature is raising. I'll talk some of the things which are in my presentation regarding the glaciers in Nepal. But most important is the second question. I'm interested by profession also. The community participation word is one of the most abused, if I am able to say, word in our after Alma-Ata declaration. Everybody talks about community participations. What is the community supposed to do in climate change? What is we have handed over to them? Is the health system or governance has addressed that issue? I mean, it's not episodically 1 or 2 places in a project successful, some ventures are there. So what could be the issue to increase the community participation in mitigating the effect of climate change? That will be the million-dollar questions. How we can make the community, starting from climate literacy to some technology, device, how the community is supposed to do that. We have that tools to offer them? Did we develop anything? Like, I'm happy that colleague from Manu Gupta said some of the area which engineering has designed, but it is an urban setting, very focused, localized, those who can afford. That is what we are doing today. But what is the people who are living in the coastal area and doing fisheries? What is the offer to them for us regarding the climate change and their vulnerability and their improving their nutrition? How? And I'm not taking more time because we will have chance to talk in presentation. But most important thing is we address issue in a different way. If we would have said the climate change is a health issue, would have been more addressed, better addressed than saying climate change is economic issue. Economic issue is with a certain group of the people. Economy is now with the 100 in the hand of 100 people. So why 99% people worried about the economy of climate change? Because anyway they have nothing to lose in terms of economy. If we will be able to convince them it is a health issue, maybe the people will understand that it affects me also. Otherwise, we will be having a little bit difficulty to make the community participation. I think that this is, so someone used the word campaign, and I like that. I like that. We have to go with the campaigning, that this is the individual, family, community, and country at large has to drive some of the campaign.
Thank you very much.
There is no question. Thank you.
Yes. We can discuss further during when you're talking about it.
Thank you.
Thank you very much, sir. Now, so call upon Professor Shakil Ahmed from Bangladesh. Over to you, sir. Shakil.
Very much, sir.
Yes.
So the thing I have already talked in my earlier, that the health community, health community, especially in Bangladesh, I can talk on Bangladesh, I can't talk about the other countries, are not still prepared for it.
Okay, fine. So I got the answer to that. Yeah.
So that's the area where we need to work from the very beginning and from the very scratch, in fact. Thank you very much. That's all.
Thank you very much, sir. So thank you very much, Dr. Shakil Ahmed. Now I call upon Dr. Manu Gupta ji. Please go ahead, sir.
Yeah, I just to add, Dr. Paramesh, you know, I'm a habitat professional here, and we are very well aware that most of us in South Asia have inherited this legacy from the colonial rulers. And incidentally, all our building bylaws, you know, originally developed in England as a response to the worsening health condition during the early 1920s. And that's how the revolution around urban bylaws, building bylaws started. And today, I think my response to this question is that we need to relook at our building stock, building bylaws, building regulations to enable better health of communities in light of the climate change problems, in light of these new kind of risks that communities are facing. You know, we have spoken about urban heat, the sea level rise. These have not been incorporated as health risks in our building bylaws so far. And that's, I think, my call to action to all of us, that perhaps we need to work together to relook at these legal and techno-legal institutional mechanisms to respond to the challenge that we are talking about. Thank you.
Thank you very much. I think we are right on time. I will just finish that one and over to our moderator. Okay. So welcome back all the faculty members and the participants after a short break of 10 minutes. After hearing the nice panel discussion, some of the concluding remarks will be coming at the end of the session. Now let's move forward the country perspective regarding tackling the malnutrition, coastal health, and urban heat. What are the challenges? What are the solutions? We like to hear from each of the countries. First, I will call upon and Dr. Aakash Shrivastava. He is from India. I think each country's highlight, we did it in 2020. Samuel Langham Clemens, otherwise nickname was Mark Twain, heard about it. He is an American writer and author, 1835 to 1910. What has he mentioned about India? India is the cradle of the human race, the birthplace of human species, the mother of history, the grandmother of legend, and the great-grandmother of tradition, are most valuable, most instructive materials in the history of man are treasured up in India only. That's what Mark Twain said about our country. We feel proud of that one. Sir, please go ahead. So just highlight, you have 15 minutes time. 2 minutes before I'll like give a tinkle for you. Remind you.
I'll start with sharing my slides.
Yes, sir.
What we're talking about today is about the initiative that has been taken under the National Program on Climate Change and Human Health to make health sector climate resilient in India. To give a background, there is a Prime Minister's Council of Climate Change in India, which used to have 8 missions. And it was in the year 2015 that they introduced a new mission, the Mission on Health. The Ministry of Health and Family Welfare, Government of India, was identified as the nodal ministry, and the National Center of Disease Control was identified as a nodal agency to support the nodal ministry. To begin with, in 2015, a National Action Plan on Climate Change and Human Health was initiated to be prepared, and it was ready in a couple of years. And then there have been revisions to it. The recent revision happened in 2021. The goal of the program was to reduce morbidity, mortality, injuries, and health vulnerability to climate variability and extreme weather. And in order to implement that National Action Plan on Climate Change and Human Health, under the National Health Mission of the Ministry of Health, which is a fund sharing mechanism between center and state, a national health program by the name of National Program on Climate Change and Human Health was initiated in February 2019. Looking at this diagram, we can see on this figure that the impact of health is multifaceted. The impact of climate change on health is multifaceted, and there are so many subject areas which have to be addressed where we find this impact. And therefore, when we were working to make this program, the idea was to try to cover as many subject areas where climate change impacts to be addressed. Now, while we have different areas to be addressed, different subject areas, all of them are addressed through 5 key methods, and that's what are the 5 key objectives of the program. The first is to generate awareness, that is through IEC campaigns, through sensitization workshop, by issuing advisories to the government. The second is capacity building, that is training of health professionals from program officers to medical officers to health workers, preparing SOPs, guidelines in relation to how these health professionals are going to work in those areas, and having knowledge exchange workshops. The third is strengthening health sector preparedness. That's through health adaptation plans, that is climate sensitive diseases and climate sensitive issue specific plans, vulnerability assessment, enhanced surveillance of certain impacts, early warning, alert and response system, and making the health infrastructure resilient and green. And the fourth is collaborative partnership, synergizing interministerial efforts, collaboration with other missions, other national programs and organizations. And the last is steering research for climate sensitive diseases with Indian Council of Medical Research. So these are some of the work that has been done in the last since 2019, and we have to understand not much progress could happen because these years were also, the country was impacted by COVID and the health department were terribly busy addressing COVID issues. So in the area of generating awareness, we started with working on seasonal advisories on air pollution and heat waves, which would come out every year before the summers for heat waves and before the winters for air pollution. We would have IC campaigns on climate sensitive diseases through all possible media, print, audio, visual, social media, and various local methods. Many states would do paintings on the wall. There will be paintings on the State Department buses. So there are various types of IC's campaigns that has been done under the program by different states. Sensitization workshop. We design flip charts for children, for women, for certain occupational groups like traffic policemen, municipality workers. We involve Panchayati Raj institutions we today in the morning were talking about community participation, bringing together the village people and discussing the problems and solutions to them. And then we will hold campaigns on international days. Some of the prominent days that every year we work on would be the World Environment Day, and in September, there's a whole week of work for clean air, for blue skies. And this year, the theme was related to planetary health, and therefore on the World Health Day in 2022, we had a lot of countrywide campaign run on this subject. In context of capacity building, we have trainings for the district and the state level program officers, that is training of trainers. We train the hospital surveillance officers, officers involved in surveillance that we run through hospital-based surveillances, and training of medical officers and health workers by the state governments. And developing training modules and infographic handbooks so that our medical officers and health workers can understand the subject related around climate change and its impact. We have a program, quarterly newsletter, which we circulate the work done by the program office, whether at the center or at the state level, so that there is a sharing of best practices among the state governments. We do review meetings, and the last review we had was this month in Kerala, and all state program officers get together and we discussed an important topic in the program. Then, as I was doing today in the panel discussion today morning, we were working towards inclusion of climate change in teaching curricula. We've been working with 6 councils, the council that is the National, the Medical Council, the National Board of Examination, Dental, Nursing, Homeopathy, and Indian Medicine Council, so that they can at least introduce it in the teaching curricula. And then from that, we will move to the non-medical area, non-medical teaching departments. In context of strengthening health sector preparedness, we're working to develop national health adaptation plans on climate-sensitive diseases. We've already developed one on air pollution and health and heat and health, and the many others are work in progress and should be available in some time. The centers of excellences have been identified for each of the climate change related health impact, which are specific institutions of expertise in the given health area, and they have helped us in developing the adaptation plan, the guidelines, the training modules, and undertaking training of trainers. Then, as I said morning today, each state have been asked to develop a state action plan on climate change, which addresses each of the subject areas, and maybe in times to come, we'll be able to go down to the level of district action plan on climate change. Then vulnerability assessment, that's another work that we are working on. And then some of the diseases we have initiated disease surveillance. One of them is acute respiratory illness in context of air pollution. We initiated it in Delhi. Now we have almost more than 10 states and union territories reporting to us on a monthly basis. We have heat-related illness that we do in the months from March to July, August. It's in the 23 heat-prone states. And we are trying to put them in the integrated health information platform, which is a digital platform on which all other health programs are operating as of now, so that there can be an exchange of health-related information and try to tap in environmental variables on the same information platform. And then we are planning to bring in other climate-sensitive conditions into this surveillance system. For early warning alert and response system, we have a work in progress for dengue. We are working with TDR Geneva, who have identified a methodology by which, using climatic variables, we can identify alerts for dengue outbreaks. We identify heat wave alerts with the help of IMD, Indian Meteorological Department, and alerts are sent out to all state health departments, who in turn send it out to the district levels. And we also generate AQI alerts with the help of the Pollution Control Board. We work in the area of green and resilient health facilities. The main areas in which we have initiated work is energy audit, solar energy use, LEDs instead of the other lighting systems, and rainwater harvesting in primary health centers, community health centers, and district hospitals. Funds have been allocated under the project implementation plans funding system under NHM every year. And this year in Kerala, we had a meeting on this subject, and we showcased to the state program officers how wonderful work has been done in Kerala in developing flood resilient facilities, and also facilities which were previously affected by the floods, how they were subsequently redesigned, and how other green measures have been planned in these healthcare facilities at Kerala. And then we've also provided an inclusion of these guidelines in the Indian public health standards, so that in future, whenever these facilities are developed in the countries, being green and resilient will become compulsory guidelines. In context of collaborative partnerships, there is a very high-level interministerial committee chaired by both Secretary Health and Secretary Environment together. They co-chair this committee, in which representatives of all other ministries come together. We initiated it in 2020 for the first time. That was the first meeting, and then we had the second meeting this year. And this is a manner by which environment and health matters will be discussed together. We also work with other national missions, especially these two missions. We are members on their board, the Mission on Sustaining Himalayan Ecosystem and Strategic Knowledge on Climate Change. We work on other programs, whether health programs or non-health programs, the Centers of Excellence, about which I was talking earlier, and then national and international agencies. In context of research and development, it is primarily the Indian Council of Medical Research who has taken the role to develop a strategy on climate change and environmental health. We only receive policy input from them and therefore take over the required actions that are required. We support Ministry of Environment in the one of the initiatives that they have of environmental health profile study for 2020. We developed a compendium of India-based air pollution research compiled with contribution from over 30 institutions and can be found on our website. These are the centers of excellence identified according to the climate sensitive health issue subject, which is known as per that figure that I showed in the earlier slide. And all of these institutions work on those specific subject areas and help us and the state in developing adaptation plans, in training modules, in SOPs, guidelines, and providing training of trainers, best practices, etc. So the implementation framework of the program is that we have a three-tier system. At the central level, it is the National Center of Disease Control along with the ministry. At the state level, in the Department of Health, there is a state environmental health cell where we have a state nodal officer for the program, and they are provided with two or one contractual consultant to support them. There is a multi-sectoral task force which is headed by the mission director, NHM, or the principal secretary health, depending upon the state, and a state governing body, which is a higher level policy body, which has either chaired by the health minister of the given state or the principal secretary, depending upon the state. At the district level, we have a district nodal under the program and a district task force, which is chaired by the district magistrate. And at the sub-district, it merges with the NHM and working to village and communities through Panchayati Raj and the design systems under the health system. And this is how, in terms of figures, you can see at the national, state, and district level, we are working in this program. Some of the IEC posters that we have created under the program. We create the template in English and Hindi, and then different states try to translate them or use the content to design their own posters. We design IEC's videos, and the states also use the content to either translate or develop their own. Some of the training that have been taken at various levels, right from grassroots to medical officers to program officers level training. These are technical documents that we have developed. This is the action plan on air pollution, action plan on heat, and also some infographic books for the health workers for easy to understand. Then there are manual training flip charts that have been designed for professional groups such as traffic policemen and municipality workers, women and children, that can be used through Panchayati Raj in community level orientation about the issues. Advisories and a snapshot of the newsletter that we take out every quarterly. Then looking into the surveillance data, there's a very simplistic surveillance system that we have. We just record the number of footfall of acute respiratory illness in the emergency hospitals of the cities that are enrolled, and then we calculate that with the AQI values of the given cities. And though it's very broad data set, we do get to see some sort of a trend of how there is a rise of the footfall of acute respiratory illness in the emergency department, along with the rise in the AQI values during the winter month. And so it's
Excuse me, Dr. Aakash, you got 2 minutes to conclude.
Yes. And then this is one that I was talking about, the working with the TDR Geneva to develop a system, and you can see on the graph below how at least 4 alarms can be raised using the mean temperature based on the available endemic channel that has been developed from previous historical database. And in context of what we were talking about today, today's topic is about nutrition, coastal rich and heat. These issues are very important, and the program is trying to address them in similar manner through those 5 key principles that we have. And that's it. Thank you.
Thank you very much. Very nice of you, sir. And let's move further. And question and answer will be at the end of the complete session, sir. Now I call upon Dr. Aditya Pradhimna, sir. Over to you, sir.
Thank you. Thank you, Dr. Paramesh. Very nice to hear the inputs from Dr. Aakash. Thank you. I will focus mainly on nutritional insecurity and urban heat, not so much on coastal risk, because personally I don't have much experience in that area, but in these 2 areas I have some experience. So talking about the major challenges and potential solutions in this context. So first, to understand the Indian context, because I was told to talk about the country perspective. So India is ranked as one of the most vulnerable countries to climate change. And I think in general, South Asia is a region that is very vulnerable. And let's try to understand why this is the case. So India is, of course, a very large country. We have several agroecological zones, a very long coastline. We have large semi-arid areas. We have very tall mountains, a lot of areas covered by forests and desert as well. So, and there are people in all of these agroecological contexts. So the kind of local lived experiences that each of these communities have is quite different, and the kind of hazards in the context of climate change that they will face is also quite diverse and different. About the country's achievements in terms of health gains and in terms of education, we see that infant mortality rate, for example, has been addressed quite well over the past several decades, and it has dropped from what it was at the time of independence in 1947. Access to education has also improved. Life expectancy, which is overall telling us also about health and other determinants, has improved over the last several decades. But despite all of this, there are significant persisting development and health related challenges, and I'll elaborate that over the next couple of slides. One of the other things is that majority of the country is dependent on climate sensitive land, primarily agriculture. So with most of the country dependent on agriculture, which is very much dependent on the climate, a large part of the population automatically becomes vulnerable to changing climate. And the context of poverty as well is also a very prevalent challenge. It is linked very much to this prevalent climate sensitive livelihoods in the country. With challenges in the agricultural sector, we also see that a lot of households migrate to urban areas and are faced with new sets of challenges after having migrated to urban areas. And with this, we see large disparities in terms of health and social indicators between urban and rural areas, and also within urban areas, large disparities in health. I'll talk about that in the next slide. The country is also in the situation where it is undergoing a demographic, epidemiological, and sort of urban-rural transition, we can say. So population at this point of time is still largely very young, But it is over the next few decades, we'll see that this becomes important because the proportion of elderly is projected to increase quite a lot. Epidemiologically, non-communicable diseases are becoming increasingly important in India's context. And India is also urbanizing with a lot of people migrating to urban areas for better opportunities and also because of distress in rural areas. There is also the situation of inadequate health and other social services, which is somehow largely related also to the low priority and low financing to some of these sectors. And I'll try to elaborate on that as we move along. And in the midst of all this, we see that, of course, this is a nation that has developmental aspirations. And in the context of climate change, there are also commitments that have been made to mitigating climate change, besides adapting to climate change for the large vulnerable population that exists in the country. A little bit more about the health disparities as we see in India. So one is, I'll just focus on a couple of points here. The growing prevalence of non-communicable disease leading to the situation of double burden of malnutrition in the country. So we have high prevalence of child undernutrition, high prevalence of anemia among all sections of the population, but especially women and children. And even in the recent past, there are some states where the prevalence of undernutrition has actually increased, which is definitely a matter of concern. About non-communicable diseases, we see that an important point is that often we think of non-communicable diseases as the problem of the rich sections of the society in the Indian context. But the data is actually suggesting that the prevalence of hypertension and diabetes are almost comparable between the poorest and the richest sections of the population in India, which is definitely a matter of concern, because these are lifelong conditions. They require treatment which can be expensive to access and can lead to very serious health problems, which can be a huge financial burden on the households, besides all of them making people more vulnerable to the health impacts of climate change. Quickly, to understand about access to healthcare, firstly, we see that especially in the urban context, there are inadequate numbers of public healthcare facilities, especially the urban primary health centers, for example, which are important in tackling climate sensitive health problems. There is a huge shortfall in several states. And in both urban and rural areas, distance to access governmental health centers has remained a challenge in many places. Secondly, when we speak to people about utilization of health services in the government sector, there are several challenges that they face, including the lack of respect that patients are experiencing in the context of accessing healthcare. They also say that the services are not adequately comprehensive within the public health centers, and they are often having to be referred to other centers, and this creates a challenge in quality and comprehensiveness of health services that they experience within the health centers. In addition, there is the cost of services becomes an important challenge. Of course, the cost of services is much lesser in the public hospitals, as it should be, and it is almost 6 to 7 times higher in private hospitals, as can be seen in the bottom of the figure here, in the last line of the figure here. But still, most people are still deciding to access private healthcare facilities. And this seems to be counterintuitive, keeping in mind the costs of the private healthcare centers, but they have a variety of reasons for this. And because they have to access private healthcare, there is also the component of cost. And because there is a cost, they delay accessing healthcare. And because of this delay, they become more ill, and they become also in that context more vulnerable to the impacts of climate change. Very briefly, to give a summary of expected changes in the context of climate in India over the next few decades. So this is from a report that was put out by the Ministry of Earth Sciences in India in 2020. So already we know that temperature has been rising, and the average temperature is projected to increase by another approximately 4.4 degrees in the worst climate change scenario, that is the RCP 8.5 scenario. And the frequency of heat waves is expected to increase 3 to 4 times higher, and the duration is expected to double. So these are all matters of concern. About rainfall, overall, there has been a decline in monsoon rainfall over the last several decades. And the models suggest that there's going to be an increase in the variability in monsoon precipitation and also increase in daily precipitation extremes. Both of these are problematic from the perspective of agriculture, the primary livelihood in India, and also from the perspective of extreme weather events, including the intensity of tropical cyclones, which also they say is going to increase. About drought, the frequency and extent of drought has been increasing in India, and these are expected to increase even further in the context of climate change. Briefly about sea level rise is also expected to increase by around 30 centimeters, which can affect various parts in coastal areas in India, especially the cities such as Mumbai and the areas in the Bay of Bengal area near Kolkata and other areas. Finally, about the climate on the Himalayas, they are expecting the temperature to increase even higher to 5.2 degrees Celsius under the 8.5 RCP scenario, and a decrease in snowfall, all of which will lead to potentially faster melting of the Himalayan glaciers, which is of great concern. Coming to undernutrition and food insecurity due to climate change in India. So firstly, important mechanisms of drought and storms which impact crop survival, especially in areas that are already food insecure, is a major concern, which can further aggravate undernutrition and food insecurity. Secondly, the increased heat has been already shown to affect the productivity of farmers. And with lower productivity, the ability of farmers to work outdoors is compromised. And so their ability to adequately engage in agriculture is also compromised, leading to lower productivity of the farms themselves. In addition, it's not just the agricultural sector. We are also looking at other ecosystems such as water bodies. Fish is an important source of nutrition for various communities in India. And the lower productivity of ecosystems, either due to ocean acidification or due to increasing temperatures, is also a matter of great concern. And also in the context of forests, in terms of wildfires, the impact on various species can all affect nutrition of communities that are most vulnerable. Finally, the melting of the Himalayan glaciers may be the most significant threat in the long term, with almost half of India's population dependent on rivers, emanating from the Himalayas for both livelihoods and nutrition. The melting of Himalayan glaciers can be very significant in terms of ability for India to produce adequate food, to use water for domestic and livelihood related needs, severely compromising the nutritional status and forcing people to migrate, all of which can be matters of great concern. So the earlier IPCC report, this is not the latest one, this is the one before that, had projected that undernutrition might increase by the order of 7 million in the context of South Asia due to climate change by 2050. So the measures addressing food insecurity and undernutrition in India, which are already in place. So we have various sorts of programs aimed at supporting food production and livelihood, such as watershed development programs, livelihood missions, which is the Mahatma Gandhi National Rural Employment Guarantee Scheme. There is crop insurance to protect farmers from the distress caused by extreme weather events and drought. All of these are, aimed at reducing the vulnerability and improving resilience in rural and semi-arid areas. There's also the the livestock mission, which has some nutrition focus, which is interesting. There is some nutrition focus in the livestock mission to ensure that the most vulnerable communities have alternative sources of livelihood and alternative sources of nutrition. There's also the mission for horticulture and the sustainable agriculture mission, some of which there are the nutrition focus, but there can be more nutrition focus in some of these programs to make them more nutrition sensitive, so that the communities can benefit not just from a livelihood resilience perspective, but also from improved health. From the perspective of food access and distribution, the National Food Security Act ensures that households, millions of households across India are able to access food grains on a monthly basis. And more recently, there is talks about how households that are migrating to urban areas are also able to access the food welfare schemes. There is also the integrated child development services that are providing nutritional packages to children, adolescents, and women in reproductive age group, especially the pregnant and lactating women. These are the things that are already in place. But the aspect of food quality in the context of this program, and also food waste in general in India, are things that need greater focus. About the health system preparedness in the context of undernutrition, there is already screening of vulnerable populations that often happens in the creches in rural and urban areas, screening in terms of antenatal care for pregnant women. There is nutritional supplementation. There is also the water, sanitation, and hygiene related interventions in the context of Swachh Bharat mission, which are important to make sure that people are not becoming undernourished because of infectious diseases. And there is also treatment for children who are identified as severely undernourished in nutrition rehabilitation centers, and there are these reporting and referral mechanisms. But of course, all of this does not solve the problem of undernutrition, but at some level is the tip of the iceberg, you can say. There is a need for stronger intersectoral action, and this was highlighted in the National Nutritional Strategy of 2017, saying that there is a need to work across sectors if nutrition has to be addressed, and somehow the operationalization of some of these ideas needs to become stronger. Quickly to talk about urban heat island and this idea of sustainable urban development. So there are confluence of factors in India that might make the population a lot more vulnerable to urban heat. One, heat itself is increasing in the context of global warming, and in the context of urbanization, increased concretization, loss of water bodies in urban areas, and loss of green cover. So that is already happening. Then secondly, as I mentioned, non-communicable diseases are
Excuse
increasing.
me, Dr. Aditya,
Yes.
you have 2 minutes left.
Yes, I'll finish in 2 minutes. So increasing non-communicable diseases, making people more vulnerable to NCDs, more migration of vulnerable communities to urban areas, differential adaptation options in terms of access to cooling and healthcare, and all of this. So without adequate intervention, effective interventions, impact of heat would surely increase greatly. I'll not talk about this because I think one of my colleagues is speaking about how the structures affect exposure to heat. So I'll just move on from here and what people are doing. So finally, the message that I want to leave you with towards health-centered sustainable urban development in the context of heat. One is we have to be thoughtful about urbanization, thoughtful about migration, aging populations, comorbidities, the various aspects related to social, economical, infrastructure, and ecological aspects. Better understanding of urban vulnerable populations. So partially this is related to the vulnerability assessments that Dr. Aakash was talking about, but a closer community connect as well with the health workers and the health systems with the vulnerable communities. The investment in health and equity, I think, should be a very important focus. There is a need to finance for health from the government, strengthen public health in India in general, not just for the sake of climate change. Include health in all policies, talk about health and equity as important principles upon which we should do development planning. And finally, learn from experiences. For example, what Dr. Aakash mentioned about floods in Kerala in 2018, the fact that they are now thinking about flood resistant health systems. Those sorts of experiences have to inform how health systems are planned. So I'll stop with this. Thank you. Thank you very much.
Thank you very much, Dr. Aditya Pradhimna. Okay, next talk would be Dr. Paraske Pokhrel from Nepal. That is a great country with majestic mountains and the tallest mountains of the world, Mount Everest, a motherland for the brave Gurkha soldiers. So welcome to you, sir. Please go ahead.
This is where I just want just to introduce. I'm from Nepal, and it is a landlocked country between two giant India and China. It covers around 147 square kilometer and it stretches approximately 145 to 241 kilometer from south to north and 850 kilometers east to west. So mostly it is surrounded by Bihar, Uttar Pradesh, Uttarakhand and Bengal and touched with the Sikkim. And other part is a Tibetan Plateau. If you look the geographical distribution, this is a hill, and then mountain, and then Tarai. This is a geographical belt of Nepal. Keep changing slides, please. Yeah. This is just to show land cover. Next slide, please. Next slide. Yeah, there is a talk about glaciers. I just want to touch about that. One of the photograph in next slide. You just see this. One of the, yeah, this is what happened in 1956 to 2007. The complete glacier has been disappeared. So this is the immediate threat and challenges in the Himalayan belt in Nepal, which is a well documented that the complete glacier in Kongama in the Himalayan belt is no more in Nepal. That has been completely out. So if this happens to other glaciers, we have a challenge with the inhabitant nearby Himalayan belt, plus the flooding in Tarai, and ultimately being desert in such a beautiful landscape of Gangetic belt. Next. This is a snow line has been migrating upward with the rainfall replacing the snow. Even Mount Everest is not fully covered with the snow now. It's somewhere we can see the dark spot when we are traveling by the flight in some occasions, which used to be very well covered with the snow and ice storage. And it is a limiting nowadays with the many changes has been recorded scientifically as well as there is intraocular evidence. You don't need science for that to see that there is no snow in the mountain. Next slide, please. So who are at risk? Mostly children, women, and the people living in this bank of the mountains in relation to the glacier melting. Next slide, please. One of the immediate threat we have noticed is the vector-borne disease is increasing in Nepal, especially dengue, and which was not reported before 12, and now it is a frequent outbreak. Even within the COVID outbreak, there was 1 or 2 outbreaks of dengue, which was very difficult situation. Now everybody talks about respiratory illness, heat-related illness, waterborne diseases, and zoonosis that I'm not going to cover. Most of the earlier speaker has touched it. And why this impact has been directly, indirectly so strong, and why we are leaving behind. Many of determinants are so far known as social determinants, but in recent time, many people started to say it is a more than social. It is a commercial determinants, deforestation, urbanizations, unplanned population migration to the urban area from rural area. All these are commercial determinants, and unless we address the commercial determinants of health, climate impact of health is very difficult to mitigate. Next slide, please. Now, if you look the capacity building and sustainable livelihoods, we have sustainable development goals, and there is a huge talk on that. The center of sustainable goal is what modality of development we are going to do. Someone has said that health policy above all the policy, and there is a awareness about climate to the population. But do this small scale of interference will preserve the species and forest and glacier, or we need to do some very important interference to control this, like improved resilience, sustainable water resources, and social inclusion are local issues, and that could be addressed. But when there is a glacier melting, it is not a local issue. It is directly related to the rising temperature, and that may not be our contributions. The contributions, the trigger is somewhere else. How that we could address is a challenge for today. Next slide, please. Now, tackling malnutrition, some of you, as some of my earlier colleague has nicely presented that there will be a challenge, but Nepal itself has two phases of nutrition deficiency. One is the micronutrient deficiency, which is a geochemical, of course, like iodine, vitamin, and all other microelement. And then there is a food gap, and food gap is obvious to see the now it is improving, but there is a 10% wasted, 27% underweight, and very still there is a few reports that there is a phenomena in urban area that the children overweight has been noticed, but that is not the major problem. Major problem is like Karnali province, whereas always the food gap is there, because the earlier local food, they do not count as a food because they are mostly used with the supply rice from outside, the local millet and other local foods, potato and all this they used to 100 years. They are not thinking that is any more food. So the food habit has been changed. So unless there is a rice, they don't count as a food. So despite that, there is a lot of challenge to take rice in that hilly mountains by flight, and transport is not everywhere. So the stunted in Karnali province is every second child is stunted, which is very not too good statistics. Next slide, please. And this I am talking about malnutrition because there is a political insurgency for last many years, and we started to from federal government, state government, and local government. We are in a transition phase, and that is making a lot of difficulties to address health issues, because the primary issue is still the political science. So health science is behind the political science. We all know, most of you heard that the medicine is at large the politics and nothing more, which is already told by Virchow in the 18th century, the second part of 17th or 18th century, and that is still holding the situation in Nepal, because politics is still in the shaping of the geographical distributions and political administration unit. So these are the things which making people more vulnerable. Next slide, please. So what is a challenge? Challenge is being a landlocked. My colleagues should know, I think, that we were not colonized. So there is no colonial impact in Nepal. But one thing we missed by our neighboring country, India, Bangladesh, Sri Lanka, Pakistan, that not being colonized, our infrastructure like roadways, railways, hospital, universities, which is a colonial legacy to the Indian subcontinent, is not there before 1990 in Nepal. So Nepal is completely new after abolition of the family rule and starting the parliamentary democracy and then republic. So we have a huge poverty behind it. So population are still facing the multidimensional poverty because lack of education, transport, these are very obvious compared to the neighboring country. Next slide, please. So there is a certain area like in the Himalayan belt and mountain, the women's right autonomy was there, and but the adjacent area to Bihar, UP, Bengal, the females are more exploited. So there is a two different cultural impact in Nepal. Some part is a little bit matriarch, and the rest of the country is a patriarch, where the patriarch system, the female children and the female themselves are more exploited with this cultural issue, and then the conflict, Maoist insurgency, flood, earthquake, all this has impacted more first to children and women in Nepal. And agriculture system is primitive. Still there is more of the people, and mostly the people who are in capacity to do, they are migrated. Of course there is a remittance is helping to the family, but there are no people to work in the farm, so the women and children, they are mostly vulnerable to work as a labor. Next slide, please. Now the hidden hungers that we all know, the micronutrient deficiency, sometimes food is still better for last 10 years, but there is some infectious disease. Diarrheal disease has been controlled to some extent because of the bottling of the water. Now we have started recently the typhoid vaccine. I hope that one of the major threat to the enteropathies have been controlled, and others are better than before, but still a lot to do. Next slide, please. Now, basic infrastructure. I told you that recently there is a phenomenal change in sanitation, and one of the reasons for the change in sanitation is the people went to work abroad, either Middle East, Korea or Malaysia. They came back and built their toilet at their home. This is completely the foreign employment has changed the sanitation system in Nepal. Rather than boosting the Ministry of Health or Education, I feel that once they practiced in the abroad, they came and first they built the sanitation at home. That is most evidence we have noticed. And we had almost 10 years insurgency, which is a Maoist insurgency, which caused a lot of migration to the urban area, and the peace accord has helped to now to move politically forward. And addressing global warming and the pollution is there is a very nice presentation from colleague saying that whole system has been involved, districts, sub-districts, national level, state level. That I see very impressive. But in our setup, we have seen the government has started the Ministry of Environment, but did not come with such a strong mechanism to the grassroots level. The reason behind is still they are demarcating geographically and political autonomy of the local governance. They declared 3 governance: state governance, federal governance, and local governance. Local governance has to be the capacity building at the moment. The provincial government is physically present, but still the budget and all these are issues. The federal government has left many things to the local and state. So there is a changing process in the political devolution. So it is still we have to see how the global warming and pollution is addressed by national plan. They are working, but they have some vision document, but not implemented so far. Next slide, please. We all know that what to be done, but the problem is how to implement, and implement needs resources. So priority of resources is very important. How to prioritize the resources. So Nepal being the one of the vulnerable country of the climate change, of the climate fund donated by international.
Excuse me, Dr. Paraske. Yeah, 2 minutes.
Yeah, please finish it.
Thank you.
Next slide, please. Next slide, please. There is plenty of talk in heat waves. I'm not going to. Next slide, please. Next. Yeah, next. Next. Yeah, this is very important that the legislation measures are one of the area where, as a public health professional, I think that that is very important, and Nepal has taken the initiative for this. Especially this local governments has started to have the standard of housing in protection of climate change, and all this is a new phenomena for Nepal, but resources is equally important. Next slide, please. Next slide. Next. I'm not very familiar with the coastal region because I have some experience working in Sri Lanka, and a little bit that the coastal region is equally very quick challenges. There is a lot of challenge in the coastal region. People from Kerala and Sri Lanka and other part of the world will be better to express this. Already doctor said that we don't have any any connection with the sea, but we understand that the coastal region will be equally affected, and the people living in the coastal area will have to be from glacier to coastal area has to work to protect them. That much I can say at the moment. Please, next slide. Next slide. Next slide. Next slide. Next, please. I'll just finish. I'll go to the conclusion. Next. Next. Yeah. Next. I just leave this slides to look, and one more slides I have. Please say this take-home message for me is this. Today I just this no nature, no future, and this is a very catching article I read today in Guardian, and I found they have said that if we talk about economics, which I was talking in panel discussions, we may not reach to the grassroots level. We have to talk about health of the people due to climate change. And I was just touching that how many university has started the Department of Planetary Health in our South Asia. I'm thankful to that Satish and team has invited me to talk. And I think somehow we need to talk about planetary health, and we have to work in the institutional level, not the individual level, but the institutional level, that a planet has value to every one of us. And that is what the most important take-home message I want to give. And with this, I want to stop here. I'll be happy to answer, and I'll leave the slides for the audience to read. Thank you very much.
Thank you very much, Dr. Paraske Kumar. Wonderful talk. Now we call upon Dr. Shakil Ahmed. He hails from a country, from Bangladesh, a great country with lush green landscape and numerous waterways. Over to you, Shakil. Please start your talk, please.
Sir, thank you, sir, for inviting me here to talk on this August gathering. And I found that I'm the least person to deliver something. Still, I'll try to be not as focused as other people are. I'll probably be multidimensional. So this is Bangladesh. And a population of 163 million with an area of 47,000 square kilometers. And there is a brief calculation, what I want to mention here, the population density with which Bangladesh is having. If we put this population density in United States, there will be 348 crores of people there, living there. So think of 348 crores of people living in the United States instead of 34 crores. So this is Bangladesh, and the coastal region population is about 32% of total population, is 47 million lives in the coastal area, an area of 29% of total land of our country. With a coastline of 710 kilometers, 70 islands are there, and to our luck, there is a big forest, mangrove forest, the largest mangrove forest in the world, Sundarban, which is 6,000 square kilometers. So this is the coastline of Bangladesh. And you can see, this is a little bit of funnel shaped here. The shape is funnel shaped. And you can see the funnel shaped here. So the funnel shape of this one is taking the hit that is burden that is generated in Bay of Bengal, like cyclones and water waves. So these are the 19 districts here. And you can see the climate vulnerability of the districts. Let me go once again. The Sundarban lies here, and that is a protection. You can see in the next slide, you see the climate vulnerability of this area is lower than this area where the natural protection is not present. So with these words, let me go to the next thing. What are the hazards of coastal areas in Bangladesh? These are the climate change, sea level rise, salinity intrusion, cyclones, storm surge, land erosion, coastal flood, population, and recently an 1.1 million refugee insurge in that coastal belt, which is changing our demography and also the environment over there. So what is the cyclones? As I have told you, that this is the common due to funnel shape of south. And this has killed 716,000 people over the last 50 years. And the Vola cyclone in 1970, which is deadliest in the history of cyclone in the world. And as you can see here, the Vola cyclone has devastated the land, the trees and buildings, everything in 1970. As we can see, the death of 300,000 in 1970, and you can see that the Katrina, Cyclone Katrina in USA killed only 2,000. So how devastated it was then time. So the salinity again, you can see the land of salinity here, and the salines are everywhere, salt is everywhere when it's dried out, and the cultivable lands has been decreased significantly, and increasing of salinity has been steady over last 35 years. So over last 50 years, you can see the salinity was 83 million hectares in 1973. It has rise to more than 21 million hectares over the last 30 years. And what are the health hazards of salinity? Gupta has done a study, and they found that preeclampsia, maternal hypertension, and premature abortions are higher in saline area than the other parts of the Bangladesh. And it has related to about 3% of child death in the coastal community. In some areas, they calculated it as high as 20%. So the climate change is real and it is happening now. It is not something which is theoretical, which has happened after some years. It is happening now. It is killing children, killing mothers. So, though there is an improvement in malnutrition in Bangladesh, the UNICEF have published the data, the stunting has decreased from 42% in 2013 to 28% in 2019 in Bangladesh, but still the coastal area is having the high burn. So malnutrition is 46.6% in that area than the non-coastal areas. And stunting is 1.5 times higher there. So though there is an improvement in the malnutrition in Bangladesh, but the coastal area is still having high number of malnutrition. This is a joint study that is done by BRAC and the leveraging agriculture for nutrition in South Asia, the organization in 2018. They found this clear data. Why Bangladesh has tackling malnutrition is not unidimensional, is a multidimensional. And you can see the fish production in Bangladesh has raised from 7.54 lakh metric ton to 43.84 lakhs metric ton over 30 years. So this has given the thing. And fish consumption is 62 grams per day per person against a target of 60. It is not 62, sorry, it's a typo. It's 60 grams per day. And the meat production has also increased by about 3 times over the last 50 years in Bangladesh. With this, you can see the egg production and the egg consumption here has increased gradually and very dramatically over the last 30 years. So protein consumption has increased, and that is an area where Bangladesh is tackling this malnutrition. But still, we can see in the coastal area, this is not happening. And tackling coastal salinity, as I have talked about coastal salinity. So research of saline-resistant variant is going on in Bangladesh for pretty long time. And this saline-resistant grains, rice has been developed by Bangladesh Rice Research Institute and Bangladesh Institute of Nuclear Agriculture. They've developed 6 varieties, which is being cultivated in 18 districts of Bangladesh over last 15 years. The total area of cultivation is about 100,000 hectares. And total production is 386 metric ton, and average production per hectare area is 3.8 metric tons. So in this way, this is the way that this Bangladesh government is trying to save the people, serve the people from this climate change. And now I'll be focusing on a little bit of urban heat. And you can see the urban heat here, the people are suffering here. And the kids, they have to jump inside the pond to save themselves from the urban heat. So the study what have been shown in temperature variation in a month over 12 years in Dhaka city. And you can see this is the blue line, which is 2014. And you can see the steady higher level of temperature than 2020 here. And this is a study which has been done by Parveen and published in 2017. They have used remote sensing and also the land surface map in Dhaka. And you can clearly see the green areas, which is less heat, low temperature heat areas in 2002. And now you can see in 2014, the green areas in this area has been virtually vanished. A little bit have been generated in this area, but the green area is almost lost. So people have to have respite. And you see respite from the urban heat, not only by the human being, but also by the other species. What is happening in the urban heat islands in Dhaka? That one study has been conducted. They have seen how much temperature is increasing over 17 years from 2001 to 2017. And they found the daytime temperature is increasing per year by 0.03 degrees centigrade over the last 17 years. The nighttime is 0.023 centigrade. And they also found that urban and peri-urban area, the temperature difference is 3 degrees. That is, peri-urban area, the temperature is 3 degrees less than the urban area of Dhaka city. So you can understand, you can easily understand the heat. And increasing, well, that's a different thing. Okay. So impact of urban heat, as many of us have told, this has been talked before, not much of research has been done on impact on health of urban heat in Bangladesh. But the productivity has decreased, no doubt about it. And it increases the mortality and morbidity. And resurgence of dengue, as everybody has said, as a student of medical science, as I was as a consultant in Dhaka Medical College, suddenly we found in the year 2000, that the dengue has came and devastated and killed about 3,000 people in that year alone. And it has came after 36 years from 1964. And since then, there is yearly episodes. And recently, the cholera has increased in Dhaka city. And the diarrhea was, the ICDDRB, the premier institute to tackle the diarrhea, Institute of Diarrheal Disease and Research in Bangladesh, have to entertain about 800 cases of diarrhea per day in their hospital. And 25% of them came out to be cholera here. Now, I have conducted a research on the accidental kerosene poisoning in children among the child admitted in Dhaka Medical College in 2001 and 2002. And out of 154 child admitted in Dhaka Medical College, we have compared with the monthly average temperature getting from the meteorological department, that in the month of March to July, there were 104 cases of kerosene consumption. Small children used to drink it from a bottle that is kept. They felt thirsty. They went there and drank that and get poisoned. And you can see in 4 months, there are 104 cases versus 50 in our next 7 months. So here is about 20 plus cases, 21 cases per month. And here it is 7 cases per month. I can tell you in January and February, there were 2 and 3 cases. December and January, there are 2 cases and 3 cases. So with the getting down of temperature, this was not there. So this is one thing. And there is high level of political commitment from Bangladesh. Our Prime Minister Sheikh Hasina was awarded the champion for the climate in 2014 by United Nations. And she reiterated in that conference that international response to climate change, particularly that of developing countries, must therefore fully respect the UN Framework Convention on Climate Change. So this is a high level commitment. With that, Bangladesh has made a division for climate change in the Ministry of Disaster Management. And this is in collaboration with other ministries. This disaster ministry is working on that issue. Way forward. So what? Sensitizing us. This us is we who are present currently here. I'm getting sensitized from the Indian works. I am really impressed by the leaflets and other posters that the Indian government has developed for tackling climate in the health. I'd love to have those things with me if it is possible. Please send to my email address so that we can progress, we can use that knowledge. And this us is also the community, health community, the physicians community, the doctor community. We are here. We have to understand that this is a real change and this is causing so many harms. Education of diet diversity and crop diversity among the population is very important in tackling, because climate change will happen and you have to diversify your diet diversity. You have to make your diet diversity and crop diversity. And as I have shown, the green areas is vanishing from Dhaka. We have to build up green areas in urban areas, which there is a popular movement of rooftop gardening in Dhaka city. And many of the rooftops are there are gardens that build up. Those might help us a little bit. Decentralized development, because if you go on developing Dhaka city and the central part, the migration and the destruction of green areas will happen. Salinity protection by dam construction, protection Sundarban, sluice gauge construction, salinity crop development will be our aims to do. So with these few hours, I must thank you all very much for inviting me. And these are the people who are trying to take respite from the urban heat by drinking juice.
Thank you very much, Dr. Shakila. Thank you very much. It's a wonderful talk, and with supportive evidence, it makes us much more happier to hear about it. Thank you. Now I call upon Dr. Manu Gupta to present your topic, sir, and definitely over to you.
Thank you very much, Paramesh. And I'm glad that I'm speaking just after Dr. Shakil Ahmed, because I wanted to go from the national macro level picture to some very interesting practices on the ground that we have been associated with. And one such practice I want to bring and share with all of you is from Bangladesh. The other is from India. And this is really about how do we work with communities and not just be there to deliver solutions, but actually also learn from them and bring out their spirit of creativity and their innovation. And Seeds, as I've already mentioned, is a nonprofit that has been working for the last 3 decades in this kind of work of engaging with communities, looking at mitigation and adaptation practices, which are low cost, which are scalable, and which involve communities at the center. More recently, we were also enabling an ecosystem of innovators, and that's where I thought I should share two stories from the field. I hope you find it interesting. I'll try and keep that limited to my time that is there. Allow me to just share my slides here. Dr. Ahmed would recall this is from Kurel. So this is one of the case studies in Dhaka, Bangladesh, which we actually worked with an institution. He might be aware, the Dhaka Community Hospital Trust, Dr. Zaman's organization. And this was a project that was supported by FCDO and START network from UK. The project actually sought to find and support ideas that build safer communities, and being based out of Kurel, Bangladesh's informal settlement, ensuring ideas are led by local communities. And this, in a way, this typifies many of the informal settlements across South Asia, Southeast Asia. So what we learned from them has been remarkable in being able to transmit that to other parts of the region. So like many other informal settlements in the region, Kurel is one of the Bangladesh's largest and struggles from problems that come with significant infrastructure gaps, like food insecurity, sanitation, unhealthy built environment. We also heard about the kerosene poisoning, and that also is a case that I've come across in this slum settlement. But what's remarkable is the number of innovations and inventors that we came across that have sprung up from these cracks and fissures in this colony. The solutions to Kurel's problems, we realize, is not, lying in communities' weaknesses, but actually nurturing the strengths of the community. And that's the aspect that I wanted to bring about. So we decided to shift our focus from what was wrong and to what was strong here. The people of the slum are not city's victims, but they're its survivors. They have that energy in them. We began our journey of strengthening the resilience with the first major disaster of the year, which was heat waves. This was about 3 years ago. 4,000 people had died in the subcontinent during the last 4 years, and slums due to heat wave. And slums were categorized as high risk due to the occupation and built environment. Fire is a frequent hazard in urban slums of Bangladesh, but also in the region. And particularly in the hot, dry season, which is March to May, houses in slum, by virtue of their materiality, take 1/6 the time normal brick and RCC houses do to burn down. And once the fire starts, it spreads quickly due to houses being stacked together. Our journey of building resilience brought us to pressing problems of food security, malnutrition, depression, disease that were endemic to this slum and most slums worldwide. So shifting our problem to strengths led us to this person called Mohammed Rafi, who grows creepers on his roof in Kurel, and not just to keep his house cool, but also keep his family fed and healthy. A large proportion of the slum was made of immigrants who are once farmers and brought to them a rich understanding of how to grow food. Inspired by these trends, we believe that the slum can indeed become a vehicle for and pioneer of urban agriculture production. And again, Dr. Ahmed mentioned about rooftop gardening here, but urban agriculture also is contributing to 1/4 of the world's urban population. So what did Mohammad Rafi do as he addressed the local heat risk problem using indigenous innovations to reduce the impact of heat? Let me try and play a 1-minute film, sir, if that's okay. Let me just see if I can do that. 1 minute. He was the one who actually grew vegetables across on the rooftop because he was a farmer before. And because of that, actually, he could not only just reduce temperatures within his own settlement, but actually also be able to spread this across other settlements. It was a 1-minute film that I wanted to show, but I think there are technology challenges here. So I'll just move on in interest of time. These are some of those pictures that are from his there, and we could actually record how much the reduction in temperature was achieved. So moving on, I will also like to share one very short case study of Masoodpur in New Delhi, which is also a new settlement where about 5,000 migrants are living and without any waste disposal system, water supply, and of course, a very, very unhealthy building environment. What we saw was box clad in combustible material, which would grow in 10 minutes to go down in flames, and temperature inside could reach 47 degrees in such settlements. A far cry from 33 degrees, that was required for comfort and 1 hour of fire safety promised by the houses we live in. The story of Masoodpur strength started with this tragedy of 2014 fire. Community rebuilt about 1,000 homes in a couple of months. They had access to segregated waste because most of them were scrap dealers, access to wealth and material that could make things made. Slum dwellers were innovators in some way. They used old cardboards on the walls. As you can see, acrylic for windows, cycle tires to soften tin wall edges. Even pesky water drums were turned out to be assets. Even though they blocked the way, they also helped keep the house very, very cool. When vertically stacked, some community members even sacrificed their water drum space outside the drum to grow bottle gourd, which provided shade and nutrition. We came up with some transformative effects, which was not only aimed at improving the aesthetics, but also making houses more comfortable and livable. Made with bamboo ladders, this wall organizing unit not only held water drums in place, but also became a canvas for gardening, plastic bottle boards, and creeper nets that can be attached. So feedback from the community showed us that they were not just comfortable with stacking the drums to the 3rd level, no matter how much we bolstered that support. We also fixed a 3rd layer of drums that would collect rainwater. Sand, activated charcoal, and gravel could be added to make the system set up for filtration. So in just about $35, we realized that these homes could be made thermally comfortable and to some extent fire safe. We executed all these retrofits in a house in the slum and observed the change created firsthand. Readings from the site showed that the roof retrofits alone were enough to bring down the temperatures by 8 degrees. Remember, I had spoken about 10 degrees earlier, without even a simple desert cooler or an exhaust fan that we are more familiar with. And so through this very quick examples, I'm sorry about this technical glitches. I just wanted to share with all of you that such local innovations are possible. Such affordable solutions are possible, provided we give the agency to the people, provided we let them also innovate together with all the scientists, with all the professionals that are there around us and who are willing to work on this. So that's all I wanted to share, sir. Thank you very much for your patience.
Over to our moderator for question and answer session before I make the concluding remark.
So we have 3 open questions. So the first question is, how can we sensitize climate-related health risks and take these solutions to the vulnerable communities like the coastal commons or the indigenous communities, etc.? So it's an open question, sir. Anyone can.
Go ahead. Anybody can answer it?
Well, sir, this is Professor Shakil from Bangladesh.
Yes.
So sensitization is a way of getting people aware of the thing. And the people who are living in the vulnerable coastal communities, they are actually away from many of the urban digital systems. So the one way is through the local community awareness, that is by, say for example, the schools, the worship areas, say the mosques or mandir or church. These are the areas where we can talk, where people can understand that this is a problem and this is a problem of their health. And they are understanding that they are having the problem. But also, Dr. Gupta just have said that the community, our community, the community who are thinking of it, on it, can disseminate the knowledge through these groups of people. This can be one way, I think, is my word. Thank you very much.
I just want to add to what Dr. Shakil Ahmed said just now. I mean,
please go ahead, sir.
Yeah, just to say that raising community awareness is absolutely most important. And in that, I think very important for us to be able to demystify high-level knowledge. I think knowledge has to be brought to the level that they are able to not only understand and imbibe, but also be able to practice, because it is about their survival. It is about their livelihood. It is about their cost of living in these areas, which are getting adversely impacted due to these kind of natural phenomena that we are seeing. So I think we have to go beyond the awareness part. We have to look at how do we sustain this kind of a knowledge within communities. What are those anchors that can sustain and institutionalize that knowledge in these communities? And it can't be a one-off thing. It cannot be just a set of posters. I think all of you will agree that along with this, a sustained program of intervention which allows and which creates these kind of partnerships with various stakeholders, with various systems integrated, would be the way to actually make sure that the communities who are at the front line, who are the ones who are impacted, are able to take decisions on their own, which will save their lives, which will save their livelihoods, and will reduce their cost of living. So I just want to add to that. Thank you.
I think, may I ask Dr. Paraske Kumar, in this context, he raised an issue, significant issue he raised. I want his comment. Unmute, sir. Unmute, sir.
Both panelists has answered so nicely that awareness and continuity of that awareness, but I think more than that, the enabling environment to them who is supposed to provide. Yes, he started to do that, and that is a anecdotal evidence. To continue that, who is supposed to have the enabling environment to sustain that activities in that slums? There is a governance system which will help either local or some interference from the social organization that has to be achieved and continued. That will be my worries of this local innovations. Thank you, sir.
Your concern is very well taken. Yes.
So we have a question to Dr. Shakil from Smriti. So Smriti, would you kindly share your question?
Yeah, thank you so much for everybody's presentation, especially this one to Dr. Shakil. I noticed your presentation, but I would want to have more information on the slide where you showed the satellite images on the urban heat part. So I would want to understand, is there some mitigation under study to see why those zones under green have turned red? So it's one of your slides, and I would like it if you could also show us that slide again, because I think that was something very important to note, and also a takeaway message for many countries.
So this is the study that has been conducted. They have conducted only the study of urban heat on the remote sensing and the surface temperature. Surface temperature not only of the land, but also water, soil, and the building area. So this was their study. And here it is actually not that green area has vanished. Actually, you can see the lower range of temperature area has gone away. Green area may not been gone away, but the lower area of temperature has gone away from this area. The reason is that the urban settlement is increasing very rapidly in Dhaka city. And there are multi-storied buildings, and also the surrounding Dhaka city, there are hundreds of brick building areas, which is also generating temperature around that. So with those, everything, the temperature has risen. It's not actually the green has vanished, but the slide is shown land surface temperature in Dhaka city. Probably I have mistakenly told that green has vanished. Actually, the temperature has increased in that areas. There obviously some green have been vanishing from those areas. Thank you very much. Hope you got the answer, Sriti.
Yes, I got it in parts. So what my quick concern was when I saw this map, I noticed that there are many shades in the bottom of the map where there is low temperature now, whereas it was high in the previous years in 2002. So I just wanted to know, is there some mitigation strategy around those zones where you see that those land surfaces are now low compared to it was middle and high in 2002, whereas it is cooler now? So I'm just focusing on those.
Actually, this study has not conducted on any mitigation effort, and they haven't mentioned in their study, Parveen and they have not, Parveen Sultana have not mentioned anything over there. They just have studied on this temperature with different modalities only. The study doesn't mention anything mitigation. And to the best of my knowledge, such mitigation, extensive mitigation is not there. I cannot explain this actually. I have to go back to the original article and find out if there is anything.
It does look.
And the article reference is here.
If I just add, if I can just add a point, Smriti, see the range of temperature is actually higher in the picture on the left.
Oh yes, it's 45, 20 and...
It's 20 is the lowest, whereas in the picture on the right, the lowest is 14.9. So that also becomes a factor, I think.
It's not one-to-one comparison.
It's not exactly a one-to-one comparison.
Okay. Thank you for that clarification. But good to note that there is something happening there. Yes. Thank you.
Any further questions?
Yes. So we have a question from Neeti Rao directed to Dr. Aakash. So is there a way for the government climate heat action plans to invest and help in scaling up innovations such as those shown by Dr. Manu Gupta? Dr. Aakash, over to you.
Yeah, let me step in here. I mean, unfortunately, this is not taken in the respective institutions, but we do have innovation labs that are being set up at government level, at national government level, which are looking at systemic problems and how do they can be challenged. But I think that should not be the only way to look at scaling these kind of solutions. I think we as communities in the academic sector who can look at documenting these, who can look at evidencing these, as well as the civil society that I represent here, have a role to play in scaling these kind of solutions and creating that kind of pressure with the political system to start looking at out of the box kind of solutions and allowing programs that can promote such kind of solutions. Yeah, so I think there's a role for everyone and not just the government.
Any other questions?
So we have a question directed to Dr. Aditya. So this is from Aliu Kao. So your first slides presented a situation similar to what obtains here in Nigeria. So my question is regarding lack of respect. I thought this is only happening here. How do we tackle this? Because it is making a lot of people to avoid public healthcare facilities, which are presently the hope of many, and government too, in order to reach the majority.
Yeah, it's a problem that nobody has been able to solve, I think, yet. So I don't know whether I can give any solution. See, I can maybe explain a little bit more about how this plays out. So it is a major challenge. The dynamics of corruption, of religion, caste, and language become very important mechanisms by which patients feel that they are not able to access healthcare, or the fact that the system is not respecting the individuals when they come to utilize healthcare. So all of these become barriers. But how do we make sure that people working in public healthcare facilities are sensitive about these issues? How is it that we address corruption? What sort of accountability mechanisms we may need to put into place to ensure that people don't need to pay out of pocket for accessing public healthcare? How can doctors and nurses and paramedical workers be sensitized about looking at health as a social problem and not be bogged down by concerns related to difference in language or differences in religion or caste? These are not easy questions to answer, but it requires a sort of a multi-level intervention, I imagine, starting from a social orientation of healthcare professionals, even from the stage of education, to institutions being more sensitive about these challenges and responding to them. Yeah, I know I have not answered your question satisfactorily, but
I think Paraske can add.
In one sense, the only solution I remember Dr. Manu or someone saying that demystifying the professional jargon and taking scientific message to the community in a much understandable level. The more than that, health literacy as a subject is unknown to us, and unless we make health literate to the public, they will not demand what they are supposed to demand. So maybe we have to not only the gender literacy, we have to improve our health literacy, not only to the public, to the health professional as well. So this is an area where we can invest to utilize health services better, public health services better. That is my response to this question. Thank you, sir.
Any other questions?
Just a comment to Dr. Manu, sir, that by chance when he was giving a very strong message, accidentally there is a flag of McDonald's and Coca-Cola in his picture. I guess that he will see that message will be clear that it is nothing to do with the McDonald's, Coca-Cola.
Okay.
Well noted, sir.
Yes, I think that's the right thing. I agree with you. So now, any other questions?
No, thank you very much, Vikas. So right now we have no more questions, and I further request Dr. Paramesh to go on with his closing remarks.
Yes. First of all, I thoroughly enjoyed each one of the panelists and speakers spoke very well, and they prepared their answer very well, and they kept their time. I am very proud of them. And moderator did a very wonderful job for us. I think what I understand by the panelists and talking, all the speakers highlighted that their country's health system needs further sensitization to reach the periphery also. I think we all agree further. There's no second opinion about it. The community level is their little problem, is their caste, religion, anything like that. I think Paras has mentioned about it. We have to prepare such a way that level quality education has to be done to the society for that environment. I think that we have to do it. But community education is a must. Why we can do it is because each country, the carbon footprint has to be reduced. Global warming, climate change, for climate change. I think usually we are producing around 4 tons of carbon footprint per person. Now, all over the world. America produces about 16 tons per person. So we want to reduce it 2 tons per person. How best we can individual, what we can do. International level is there, national level is there. Individually, we have to educate them. How you can reduce your carbon footprint at home. What you can do, building your houses, using the other light, offing the unnecessary energy, using solar heating system. These are all the various things are there. Individually, what we can do, have more of walking, doing all these things rather than finger exercise. Walking exercise, you can do that using the bicycle. Those are all the things we might highlight individually in a community level. What you can do, that we have to focus on that. The third thing is cost containment has raised that issue. I think we are second to none. We have enough technology at the fraction of a cost we can do it. But current situation, the medical legal issue has come there. Everybody wants if you say technically, you're clinically, you have so much of experience, you don't need an investigation. Everybody wants investigation. That is the one cost containment is going to high. We have to contain as much as possible. So nearly 90% of people want a private sector, let them pay it and go. No, nothing wrong with that. Let us not comment on that because they have enough expenditure in that context. But 10% people who cannot afford, I think government is in there, work on that. That's what I like to do that. So indoor air pollution, increase in the morbidity, mortality, that was right. That as a matter of fact, the data has come by for the past 18 years from 1990 to 1999, 2009, that the outdoor air pollution has increased the mortality 115%. Indoor mortality has come down by 63%. I think building our, so society is awakened already in that context. So now, having mentioned those issues that human and our planetary health is very closely linked, from heat waves, floods, with erosion of coastal area, and nutrition from climate change. There's no question about it. The climate change is already impacting our health system with the disadvantages of the communities. Health professionals have an ethical and professional responsibility to safeguard the health of our society and our planet. Health system must prefer to reduce greenhouse gases and carbon footprint by individual level. That's what I was highlighting earlier, along with the local, national, international level. I think during the COP26 in Glasgow, nearly 46 million health professionals signed the paper. I think professional people are not aware of that. And here, India is one of the countries signed about it. Nearly 98% of the doctors are aware of the climate change, but only rural doctors are not aware. This we have to be. This has been published in the Lancet. I was one of the coordinators of this program, WHO Climate Change. I think what we want to do, WHO says that now the universities and education stakeholders must update and evolve programs such that they address risks from the climate change as well as opportunities to improve the global public health response to climate change. A recent study showed that climate change educational program for the future doctors are lacking worldwide and are often student-led. Another global survey shows nearly 160 health professional schools indicate many barriers are being faced in integrating the climate and health contact curricula, including lack of institutional support. These are all the survey shows. To empower the health professionals with knowledge and updated knowledge and skills, they need to respond to climate change. So with the following demands, with action, we have to project it. Number one, let us integrate the climate and health competences into all health professional curricula, accreditation, and continuing professional development. Number two, let us provide a health lens to support the development of educational programs to climate change and health in other sectors, foster multi-sectoral thing. Nearly 6 sectors are there. One is the industry, 8 sectors are there. We have to be the leader, educate them in that context. And advocate for and provide additional funding for resources for climate and health research. If you look at the funds are allocated for cure, 97% of the money goes for cure for one disease. That transplant is transplant, very rare disease. Only 3% will go for the preventive aspect. In that children constitute 50% of them. Only 7% out of 100% in that money goes to children. We have to look into that aspect. And lastly, let us share the educational resources. We expand educational opportunities. With these type of things, I once again thank all of you for participating and highlighting the issues so that how best we can take it. I think we are in the stage of critical stage. If the temperature goes from here to 4 degrees, I think irreversible damage is going to happen. And if it go to 6 degrees, where up to the carbon footprint going to be the 600 part per million, no species will be existent in this world. We are totally eliminated. This is time to act. We have to project very strongly in this context. We are at a very crucial stage, critical stage as a matter of fact. And now let us not move for the irreversible stage. Let's work for that one. Maintain the carbon dioxide at each one of that at 2 tons per year. And the carbon dioxide, what we say that part per million, we have to maintain at 250 part per million, temperature at 0.15 degrees by the end of this century. So as a matter of fact, Nepal, I want to say that, sir, this is the permafrost is happening. There is 60% more increase in the pollution from the permafrost. Yes, carbon dioxide is going to increase further, increase heat, and we are going to face more problem from that one. Air don't have a limit, it will spread all over. 60% increase has been predicted with the carbon footprint, while permafrost is melting. Nature has sent a lesson. Nearly, I said in Nepal, in that area, 33 new germs have identified. 28 are new germs. We have to face the future pandemics. It is irreversible. So we are already facing nature. We learned a lesson from COVID-19 pandemic. We learned during the pandemic need to be pursued, propagated, and practiced based on scientific data for each country. So take home message, I conclude such a way. Restoring the climate is critical to the survival and flourishing of the humanity. Let us not leave dangerous conditions to our next generation. Include health in all health policies by the health makers. Focus on economy and on preventive diseases. New carbon dioxide removal and storage methods will still surely emerge. Technology is there. Finance is needed. The country who have been polluted earlier, they have to contribute. Technology already exists to restore the optimal climate 2050. I'm optimistic if we all work together, we can overcome all these things. Optimism, positive thinking in life always yield good results. Let us bring hope in all the restoration. Thank you very much for your time and patient hearing. I think let us conclude and And once again, thank you. God bless you all. Keep you good health. Let us work for the safety of our future generation and our survival too.
Thank you.
Thank you, sir. Thank you very much.
Thank you.
So I thank Dr. Paramesh for sharing the session, and I thank all the speakers for their time and their very valuable insights. So like Dr. Paramesh said, it's not just one sector, but it's all the sectors coming together to tackle the issue of climate change and health. With this in mind, I would like to invite you all to join the next section. Is happening tomorrow on the 29th, which is deliberating best practices, developing sustainable communities in India, which is by the coordinator Maitreyi Murali. And I also invite you to join for the closing, which is on 29th at 2 p.m. With this, thank you very much. Thank you everyone for joining, all the panelists and the attendees. Thank you.
Shakil, thank you very much.
Thank you, Paramesh sir, for inviting me in something extraordinary, and I hope that I have not bored you all by a simple thing. Thank you very much.
Wonderful, wonderful, wonderful.